Well, welcome, Joe Chapman. It's been quite some time since I've seen you. Thank you for making time to talk to us a little bit. Before you say anything, let me introduce you a little bit to folks who've been watching. If you've been at Westminster for any period of time, then you'll remember Joe as a seminary intern of ours some time ago. What was it? Is it 2 years ago now, Joe?
Uh, three, yeah,
3 years. Gosh,
yeah.
it's hard to believe. Well, great. Well, then we'll really look forward to catching up. Joe was our seminary intern while studying at San Francisco Theological Seminary. Before that, he was a student and remains to be a student of poetry. He taught
Mm.
at the collegiate level. He has since leaving the West Coast, he's gone to St. Louis, where he is completing a year of what's called CPE. And I guess, Joe, to start, uh, tell us how you're doing, first of all, and then tell us a little bit about what CPE is. It stands for Clinical Pastoral Education, but many
Yeah.
folks don't have any idea what that means. So welcome. How are you?
Oh, thank you. Yeah, doing well. Good to see you all at Westminster. So clinical pastoral education, you can do it in a number of different settings. The most common one, though, is a hospital setting. And what it is it's a program of training for pastoral care. So offering spiritual and emotional care to folks in need. And the way it works is that, at least in the hospital setting, it's a lot of learning on the job. So um, I'll make visits to patients or family members, and then I'll go back to a group. Usually the group is around 5 or 6 people, and you have an educator, and you'll talk about those visits, and you'll talk about what you could have done differently, what you might do next time, what you did really well. So it uses something called the clinical method of learning, which is action, reflection, action. So you do something, you think about it, you talk with other people about it, and then you try again. But typically you do CPE in hospital settings, and that's where I'm at now. I'm at St. Louis University Hospital. It's a level 1 trauma hospital, and a relatively poor city and racially divided city. So we see quite a lot of rough stuff come through our emergency department. So it's been a real eye-opening experience for me.
And how did you end up doing that? I mean, those of us who know you know your many gifts, pastoral among them, but you're a great writer, a wonderful preacher. What made you take this route, and where do you think it might be leading?
Yeah. So I think for most denominations, the Presbyterian, PCUSA included, CPE has been a required part of the ordination process for quite some time. I think, I think CPE was first getting started in maybe the 30s and the 40s, but more recently it's been a required part of the ordination process. And so I did an internship at St. Louis University Hospital to fulfill my ordination requirement. And I actually had no idea that it was going to be such an intense experience. I just liked the educator in my interview and ended up there, but I didn't quite know what it meant to be a level 1 trauma center in a poor city. So I ended up at this hospital, and I just really loved it. I
And
loved,
that would, just to clarify, that internship would have fulfilled the requirement. What you're
yeah,
doing is a year above and
yeah,
beyond. Yeah.
yeah. So I finished that internship, and I just fell in love with the work, and now I'm back there for a year doing what's called a residency, and then after that I'll be eligible for board certification as a chaplain. But I think what I love about the work is it's really about caring for people wherever they're at, whether they're in pain and suffering, whether that person is intubated and can't even talk to you, if that person is emotionally distressed, spiritually distressed, whatever faith tradition that person practices, or no faith tradition if they're atheist. I think for me, the point of pastoral care and being a chaplain is to somehow come alongside that person and care for them and let them know that they're not alone, at least for the time that you're in the room with them.
And I mean, even under normal circumstances, it can be quite an intense setting, right?
Yeah, it can be. Yeah. So the floor that I work on is a general medicine floor, and there's a lot of drug overdoses that come in. There's a lot of alcohol withdrawal that we see. There's a lot of cirrhosis. Blood cancers are on my floor a lot. And then occasionally, just because there aren't a ton of beds at the hospital, traumas will come through as well. And that can be anything from motorcycle accidents, car accidents, gunshot wounds, falls from tree stands, and all sorts of things. So it's, just the variety and range of human experience and suffering and joy that I see has been remarkable. I don't know. I didn't know humans experience this many things before I started working at a hospital.
The full range.
Yeah.
Yeah.
Yeah. And I thought that a big question for me before I started this work was going to be, where is God in this?
Yeah.
Why does God allow suffering like this to happen? But I think the real surprise for me has been the amount of care and compassion and joy that lives alongside suffering in these hospital rooms. The closeness and the intimacy of families, the way that they care for each other in surprising ways, the resilience of patients, all that is living alongside incredibly intense and sometimes chronic and prolonged suffering.
And so those have moved, what you thought were going to be the questions have just not felt like the questions?
Yeah, exactly. Yeah, those questions have fallen away.
Interesting.
Yeah.
You mentioned joy a moment ago. I mean, I think many folks, myself included, when they enter into a conversation like this, expect to hear about the trauma and the heartbreak and the pain. And I don't know why, but I didn't expect you to say joy. So talk about the joy you've encountered.
Yeah. Let me try and think of an example that might bring suffering and joy together. So I have seen merciful deaths, deaths where someone has been hanging on. Just recently there was an elderly man who was, his daughters were with him. He must have been in his late 80s or early 90s. Because of COVID, his wife wasn't allowed to be with him, but we brought an iPad into the room, and his wife was at a nursing home, and she was able to watch him die. She was able to see him as they pulled the tube out of his mouth and extubated him, and watched him as they took all the machines off of him and moved him to what's called comfort care. So the only things that we were doing was making this man comfortable. And he held on for a little bit, and his daughters who were in the room were getting a little antsy and worried and wondering why he was holding on for so long, and wondering if he had any unfinished business or anything that was keeping him here. But eventually he did die, and it was joyful. It was joyful because there was a letting go, and he was finally at peace, and they were not waiting around anymore for this death to happen. So I think that happened, and but he left behind a wife. I think they'd been married for more than 50 years. But so there's going to be incredible suffering for her, but there's also joy in that release and finally being at peace.
Wow. That's quite something to be in the room for that.
Yeah. There's, there are a lot of, I don't experience death every day, but maybe once a week or something like that, someone on my floor will die. And so I'll be in the room, or I'll be with them. And the patient will die during the night or before I get there the next day. But so yeah, it's a real, I think that's part of it too. It's a real privilege to be with families in these moments of vulnerability, and these very intimate moments.
Has anything surprised you about those moments or about being present around so much death?
Yeah. Also the humor that people use.
There's a story there. There's a story behind that, I'm sure. Or more than one.
There was a young man, I think he had just turned 33. He had had leukemia for 10 years, and he was dying. And I was with his mother for probably, oh my gosh, it must have been, I saw his mother almost every day for about a month while they were in the hospital, maybe longer. But his sisters would visit, and they had the darkest, funniest sense of humor. Like I would laugh with them, but while I was laughing with them, I was like, I don't know if this is okay. But that was how they coped, was through humor. And I'll see that with other families too. And it can be really beautiful. And then telling, the way families will tell stories about their loved ones, and how stubborn this person was, or ridiculous things that they did. So it's been a real surprise for me too, the way that the joy lives alongside suffering, but humor does too.
Oh, interesting.
That surprised me.
Yeah, I wouldn't have necessarily paired those. Now I know about what you do enough to know, as you said earlier, that the job is primarily about coming alongside, and yet even for those who maybe don't belong to tradition, you do carry, perhaps in people's minds, some sense of authority around spiritual matters. And I can imagine that around death, for example, there'd be a moment where somebody turns to you and says what's going to happen, or what's it going to be like, or what happens after you die, whether it's about them or their loved one. Do you ever get that question? And if you do, how do you handle that? What do you say out of your own conviction, and what do you leave up to them? How do you frame that?
Yeah. I think sort of the most common response you'll get from a chaplain in that situation, and from me too, is what do you think happens? So to turn the question back on the family member or the patient who's asking this question, because it's not important what I think, it's important what you think, and let's work through your idea of the afterlife, or your idea that there isn't an afterlife, and what does that mean for you? And is this commitment, belief or commitment giving you life or taking life away from you? And so that, I think the point is for me to explore what the patient or the family member believes, and if possible, use that belief as a resource to help them get through whatever it is they're going through. But the less clinical approach, so that's an approach we'll hear more in therapy, or that's kind of more standard. But I also encounter patients and family members who want to have a relationship with me. They want me to be a person, and they want me to have a belief system that they can engage with.
Yes.
And when I sense that, I will respond from my own faith. And the way I usually respond to that question is with Romans 8:38, which is, just a summary of it. Nothing can separate us from the love of God. So there's nothing you can do, we can do. There's nothing in the world, nothing above the world or below the world, that can separate us from God's love. And we might not know what the afterlife looks like, but we know that God's love will be present with us, and that we will be united with God's love. And that's the only sure thing for me, is that relationship of love will continue.
I'm really interested in hearing that, because the clinical response is familiar to me, and I gather what is often offered, and inappropriately so, I think, for reasons you stated and reasons we can all understand. But it's good to know that folks are thinking about if there is that other space created or invitation made that folks will take that step, or at least you will. Because I
Yeah.
sometimes wonder if, okay, then the person lies there and says, okay, well, I'm really scared. Well, but I want to know about your fear, which is
Yeah.
also an appropriate
Yeah.
follow-up. I
Yeah.
remember interviewing for a job one time years and years ago, and one of the pastors, there'd been co-pastors at this place. They hated each other forever. And one of them had completely lost their faith during their ministry there, which happens. But an example given to me of this is somebody was in the hospital dying of cancer. It was a woman dying of cervical cancer. And she asked the pastor to pray with her. And he said, well, I don't really believe in this, but I'll give it a whirl. And I just thought, that's theological malpractice and spiritual malpractice. And that's not to say every chaplain needs to have my belief system or any, prescribed belief system. But it's nice to know that there are people there who, if you want to go beyond just the clinical reflection kind of model, that there's someone with whom to go there with. I can imagine that being of great comfort to someone.
Yeah. And I will say this too, Rob, that one thing that I've noticed, and I'm not sure if this is an irresponsible generalization or not, but with a lot of wealthier, privileged white families, it's more often the case that if I say, well, what do you think? Then we'll start to explore what resources they have. But if it's a poor Black family, they want help. That family wants help from me, and they want resources from me. And they don't want me to say, well, what do you think? Because they have nothing. They have nothing to hold
that's
on to.
Fascinating. That's fascinating. So you attribute that to a resource question. Where my mind went, and both could be true, or we could both be off base, is there an authority question there? Meaning in some cultural communities, the religious figure has a higher authority and maybe has more permission to say, this is what's so. Whereas you've been in my context, we're here more to moderate and facilitate, but not to tell anyone what to think, right?
Right. Yeah. No, yeah. The authority, that authority is part of that. And authority is a resource.
Isn't that something? Wow. Boy, I would never have gone there, but it makes loads of sense now. Are there other, since you've opened this door a couple of times now, other things you've learned from serving in such an intercultural context, or biracial or multiracial?
Yeah. I guess there are just some cultural things that I look out for. So there was one, we had an ethics consult with this one patient who was found down after a heroin overdose, and I think it had been a while before he was found, and so he had an anoxic brain injury, and there was just really no way he was going to come back unless through miraculous means. And there was this ethics consult, and we said, the mother of this patient is pursuing treatment, even though it's really unlikely. There's almost no chance, really no chance, that this patient is going to come back. Should we seek out someone else in this family as the decision maker, since we're not making any headway with the mother, and it may be unethical to continue treatment on this patient? And so but the doctors went around or bypassed the mother, and in this Black family and in Black culture, that is a really bad idea, because she is the authority in this family. And we really, really stepped on some toes. And
were the doctors who did this, or the staff who did this, all white?
No, most were white, but actually the way it worked out was that I think the doctors were white, and then the social worker whose job it was to contact another family member was Black. Wow. So, and she was very uncomfortable with it. So it was, it was a cultural difference and a lack of cultural understanding where who's the authority in the family and who you're allowed to talk to and who's going to make these decisions.
Does that get talked about a lot where you are? Because where I am, what Marin is like, it's very segregated. And so because we've created a setting in which we don't interact that much, we therefore don't have as many occasions or don't make as many occasions to talk about such things. Surely this must come up then, serving where you do.
It does, yeah. It comes up especially in the education setting for me, in the group with the educator.
Right.
And it will also come up, it's coming up more, I don't get a chance to be in these meetings a lot, but in the ethics consults, it will come up, it's coming up more and more, the more that I've been able to sit in on those.
Interesting. Wow, that's fascinating. I remember I did the 1 unit of CPE, which for folks who are watching, that's the internship, kind of just a summer. And for me too, I served in a similar hospital downtown Atlanta, and it was in my small group too that these dynamics came up, often in a way I was operating often in a way that I was unaware of, and so I sort of felt like I don't do that, or I don't think that way, but it was being reflected back to me that perhaps I did, and that was a very new experience for me. My idea to engage you in this conversation came out of a tweet I saw where a woman, I think it was a woman, described what to someone like me seemed like a pretty traumatic day. I think it was a scene similar to one you described moments ago about somebody dying from coronavirus and saying goodbye to family members on a tablet, and really intense. And you had replied, "That's my everyday." And I just thought, wow, I've got to talk to this guy and let folks see what this is like. I think it's a moment where many of us, and perhaps it's a voyeuristic impulse. I think there's a piece of that. There's also a piece of us that have just never seen, many of us have never seen anything like this pandemic in our lifetimes. And we want information. By that, we want to know what's going on, what it's like. And so moments like that, for those of us who are still just hunkered down, kind of waiting and watching, are really alluring to us for all kinds of complex reasons. It strikes me, though, as we talk, that maybe what you're doing is not as different now as it was 6 months, that this may not be that different for you. It's very different for us. I mean, can you talk a little bit about what this particular moment is bringing and how it is or is not similar to what was happening in the hospital before?
Yeah. I will say that there is a major difference, and that's that visitors are no longer allowed at the hospital unless the patient is on comfort care, so the patient is actively dying.
What about births?
So we don't have a maternity ward at our hospital, but I believe at the other hospitals that do, those are the exceptions: birth and death.
Okay.
So and another caveat or something to note is that right now at our hospital, chaplains are not going in COVID rooms. So we are preserving PPE, personal protection equipment for nurses and doctors who absolutely need to be in those rooms. And so we will communicate with the patient over the phone or with an iPad that someone takes in the room. So that this particular example where a doctor has the iPad with the patient, and that's a COVID patient, and the patient is probably intubated, and the family is just saying goodbye to the patient, and the patient may hear them, but the patient can't respond. I'm not in those situations because I'm not in that room as of now, but if we get more COVID patients, it may become more normalized for me to be in that room. I'm not sure. I know the hospital across towns, Barnes Jewish, the chaplains are going in COVID rooms, and they have more COVID patients. But where this scenario plays out often, where I'm taking an iPad in the room and the patient is dying or close to death, this is happening a lot with patients who are intubated and can't talk, so they have a breathing tube down their throat, and the family members are not allowed to be at the hospital. So they can't visit the patient yet. The patient is not. There's still measures being taken to keep the patient alive. So at that point, per the hospital's policy, family can't be there, but they want to be able to see their loved one, and they want to be able to say goodbye. They want to tell this person that they love them. So a lot of a lot of what I do throughout the day is I will take an iPad into this room and I'll hold it in front of the patient, and the family will say the most intimate things to this person. How much they love them, that they want them to wake up, that they want them to attend their graduation, that they need to wake up so that they can see their grandchildren grow up, so they can see their children grow up. It's just heartbreaking to know what the medical chart looks like, and to know that this patient is not going to come back and not going to wake up, but then to hold an iPad in front of them with their family, who is saying to the patient, please live, we love you.
You mentioned it being a privileged role and place in that room to hold that iPad. What other words come to mind when you're the one holding that portal between loved ones?
Yeah, it's been a process of figuring out what my role is in that room and who I am. In the past, chaplaincy has been a ministry of presence. So I go into the room and I'm with the family member, and I am able, by entering that room and staying there with them, no matter how much the family is suffering, no matter how much the patient is suffering, it's a ministry of presence, because I am not scared. I'm not going to leave the room. What we do most often when someone is suffering and when someone is in pain, emotional or physical, is we look away, or we turn away, or we say something positive, something uplifting, so that we don't have to feel their suffering, and try and get them out of that space where they're suffering, because it's too uncomfortable for us. And that is the ministry of presence, is for me to be able to go in there and sit with them in that suffering and not turn away. But now in this case, I am kind of secondary.
Right.
The connection between the family and the patient. And so I'm starting to think of it as a ministry of witness. I'm here witnessing this bond, this closeness. I may not be able to offer presence, but I am here connecting the family with the patient, and I am witnessing it. Which I think there's still something soothing about that, something powerful about that.
Oh, wow. It makes perfect sense that you all would not use the protective equipment so that it could be spared for others. I certainly understand that. There's a part of me, though, that's so angry about that, though, because you're not able to do that, what you just described, for COVID patients. And I've said this before here at the church, that all these heroic acts are heroic, that we've been all praising and cheering for, but they're also all, or many of them, signs of systemic failures, because it didn't have to be that we have to ration gowns and gloves, and say, well, the chaplains should be the first to go because they're not necessary, and we need to save them for the doctors and the nurses, or whatever. That's deeply frustrating. To me. Can you feel my anger?
Oh, yeah. Well, I think, I think one of our major fears as chaplains is harming other people.
Sure.
And so if our presence was what was healing before, what if now our presence can be something that's dangerous and could actually harm people? So part of us not going in COVID rooms is not only to protect, save that equipment, but it's also so we see a lot of people, so if we become exposed, we don't expose more people, because we go in between floors. And so I think that's part of it too. But I think you're right. I think if we had enough PPE, if we had the resources and materials that we needed to keep nurses and doctors and chaplains safe, we wouldn't be using wartime language. We wouldn't need to use the language of heroes. And a lot of the nurses I talk with don't like the language of heroes. They're here to do a job, and they want to be protected, and they don't.
They didn't sign up to be heroes.
Yeah, exactly.
Yeah. That's it. I want to hear more about that, and also the wartime language, because I find the wartime language, while understandable, deeply troubling the more one thinks about it. for
Mhm.
all kinds of reasons. So tell me about how they want to be seen and the language that, and how you're experiencing language and what framing you might offer.
Yeah. I mean, I guess I would say it's hard to generalize, but I just for my nurses in my intensive care unit, um, it sort of seems like it's business as usual. It's some heightened anxiety, but what they want is they want PPE. They want the equipment that they need to do their job, and I don't hear a lot of language from them about heroism. What I hear from them is give us the equipment to keep us safe.
Wow. Wow. Yeah. It's almost as if all that kind of talk just distracts us
Mm-hmm.
from the real need.
Mm-hmm.
Yeah.
And,
So it strikes me that some people who watch this on some level may be wondering, and even though California's done a really good job and it hasn't hit here, certainly in Marin, I think we have 220 cases, but a handful of deaths, which is of course tragic, but we haven't experienced the wave like some other localities have. So I don't know how present the fear is for people, but I can imagine some people wondering, if it hits me and if I have to go into the hospital, what's it going to be like? So as somebody who's been on the inside in a lot of really serious situations, what would you say to a healthy person as they consider the potential, whether it's COVID or something else, of them being hospitalized in a serious situation? What would you say
uh,
to them that might help them?
oh, that's a tough question. Hmm. I mean, I think it would just be so particular to the person, and to I would listen for what the need is, and that need can be as unique as that particular person. Sometimes a person needs reassurance.
Mm-hmm.
Sometimes a person needs you to not look away.
Yeah,
Sometimes it's about the patient's dignity being
yeah,
maintained. Sometimes it's about connecting them with their family. I mean,
yeah,
you don't, and often you don't really know what your need is going to be
right.
until you're in a crisis and then it
Well,
pops
that's,
up.
yeah, in a sense, I think that might be what I'm asking, though I'm not sure. And that is, how does one be a good patient? And by good, I don't mean like a good little boy and girl, but a patient
Mm,
that is able to accomplish getting their needs met as
yeah,
best. Like, how
that's
does
a
one do that? Because we're not taught how to be patients.
right.
And some of us grow up like I did, just trusting every daggone authority that crosses our way. And others are more fiery in their advocacy for themselves or the
Mm,
others. And so what do you know what it means? You've
mm,
learned or are learning what it means to be a good chaplain.
mm.
Do you know what it means to be a good patient?
Yeah, ooh, that's a kind of a tough question for me.
I like asking them better
Yeah.
than answering them. That's for sure. I
Yeah.
like this end of it.
Well, in the hospital setting, I'll just say that can be that what it means to be a good patient has a kind of a moralizing tone to me,
Yes.
because
Yep.
especially in a poor city, it means, do you
Yeah.
behave well as a
Yes.
patient? Do you
Yes.
behave like a white person? Do you keep your emotions in check? Do you
Yeah.
respect the authority of the doctors? Versus,
Yeah.
are you loud? Do you make your needs known? And if you're white, advocating for yourself is something that you understand how to do and that you've been trained to do, but you don't know how to advocate for yourself in this system as a black person often. So it's being a
Yeah.
good patient. Yeah.
In this system, maybe being the operative words that the
Mm-hmm.
way you advocate here looks like this, not like
Yeah.
that. Yeah.
Yeah. Yeah. But I will say for me as a chaplain, the patients, what it means to be a good patient, or what makes a successful relationship between me as a chaplain and a patient, is if we can collaborate, if we can come together and work on meeting both of our needs, meeting my needs as a chaplain and meeting your needs as a patient. And that means being vulnerable and
Yeah.
sharing what your needs are. And I will say that the most difficult patients for me are patients who are caregivers, patients who are nurses, patients who are ministers,
Really.
because these types of patients are not used to being cared for. And
Yeah.
there's a lot of resistance to opening up, to being vulnerable, to naming your needs. When I walk into a room and it's a nurse and she's been hospitalized or he's been hospitalized, that patient often tries to care for me. When I
Yeah.
walk into the room, they ask me how my day
Oh
is,
my gosh. Yeah.
things like that. They're trying to make me feel at ease. And I appreciate that. And it's really lovely, but it's got to be exhausting. And it's got to be
Yes.
so hard to not be able to turn off that part of yourself that's caring for other people.
It would be wonderful for someone to teach us how to be cared for,
Right,
right? I mean,
right,
we don't get that education.
right.
And yeah, you see it all the time. Well, as a final question, I mean, it's kind of an obvious one, but I wonder where does hope show up in your place of
Mm,
vocation?
mm. Yeah, yeah. I mean, I think hope shows up all the time, everywhere. It shows up when a doctor goes down on one knee and talks with a patient eye to eye.
Wow.
It shows up when a chaplain holds a patient's hand. I mean, there are so many times when I visited a patient where we've had a conversation, but there have been a few times when a patient has been in a lot of pain and I've just sat by the patient and held their hand. And that contact, that's hope to me. Someone coming into the emergency department and not looking like they're gonna live, and then they do survive, that's hope. Someone, a family being able to let go of a patient who has a very little quality of life or no quality of life, that's hope. Um, I also, there was a patient with Down syndrome, and I was in a family meeting, and the doctors were saying, we need to change the code status of this patient because if this patient recovers, he's probably not going to have a high quality of life. But the family were able to say to the doctor, no, this is a high quality of life for this person, for this patient, even though the patient is disabled, or because the patient is disabled, that he is living a good life. And there's hope for me when we, as a community, can recognize a whole variety of ways to thrive, and that may not be recognizable to other people. So when there's a lot of hope when we expand our horizons for what it means to thrive.
Yeah.
And yeah, I think that is really the big question that's tied to hope for me, is where and how can you thrive in the midst of the suffering, or in the midst of more limited abilities, or a loss of abilities. So that, I mean, yeah, whether it's your own body that's failing, or you're losing abilities, or you're losing a loved one, what sort of resilience is there, and how can you thrive? And if you can't thrive, and if there is no resilience, who will sit by you
Yeah.
in that place where there is no hope? I mean, that's a kind of hope to me, is
Yes.
that someone can be with you
Right.
where there is no hope.
Yeah. Wow. Spoken like a poet. You got it. Well, Joe, this has been great. Thank you again for making so much time for us and for sharing your growth in ministry. We will be eager to follow you, but not to rush you into the future. So we'll leave it there. It's been great to see you.
All right. Good to see you, Rob.
All right. Take care.